Top Med Talk.
Well, hello and welcome to this first ever POCAPALOOZA. I'm Desiree, Chappell, your host, and exciting to be rounding out this third day of EBPOM live from London. But we started our journey in South Africa with Bruce Picard and Paul Miles and Monty. And we traveled around the world, and we now find ourselves in beautiful, sunny California in LA. Now, I'm so happy to introduce our friends of EBPOM, Top Med Talk, and the co-vice presidents of the International Board of Perioperative Medicine, Professor Carol Peden from Keck Medical Center of the University of Southern California, and Professor Lee Fleisher from the University of Pennsylvania. Both, thank you so much for joining us.
Thank you, Desiree.
Pleasure, Desiree.
Please, Carol, can you give us a little bit more about yourself?
My official title is I'm a professor of anesthesiology and a director of health system innovation at Keck Medicine in Los Angeles. I have a lot of clinical background as an anesthesiologist and intensive care physician, but in addition to that, about 10 years ago, I undertook a quality improvement fellowship at the Institute for Healthcare Improvement in Boston and did a master's in public health at Harvard School of Public Health. And I've combined that expertise in the perioperative arena with a particular focus on improving outcomes for high-risk surgical patients. In addition, I now have leadership and administrative roles, and I think those are important topics to think about, how we introduce perioperative medicine trainees to those areas.
I wanted to ask you about a paper that you published with a group in anesthesia in January 2020, and it's kind of around APORG in the African Research Group. Can you tell us a little bit more about what you did with that?
Yes, this paper was anesthesia. I think it was January, it was 2020. That Santarapila was the first author. I'm second author. Bruce Picard is one of the authors. There's a very international group of anesthesiologists on that paper. The paper is entitled Towards High Quality Perioperative Care, a Global Perspective. And we wanted to flag some of the issues around delivering perioperative care, high quality surgical care, about access, follow-up for patients, that it's not just about surgery, it's about high-quality anesthesia, it's about enabling patients to get to the venue for surgery. So just to really illustrate the real importance of focusing on this area for lower-income and middle-income countries. We did a Delphi consensus of some of the things that we thought were important. And we also, for example, in the paper, there's a driver diagram, which is one of my key quality improvement tools that I like to use, suggesting areas that countries can work on, which include governance, service delivery, workforce development, and enabling the patient population to understand how they can access high-quality care, how they can judge high-quality care. And I think it's important that while low and middle income countries may have issues that we don't face in places like Los Angeles on finance and access, many of the basic quality improvement techniques we use in perioperative medicine can work very, very well in lower income settings. So something to think about. But please have a look at that paper if you're interested in supporting perioperative medicine in lower income countries.
Yeah, Carol, that's fantastic work. Thank you so much for everything you do and the knowledge base that you bring to that. It's interesting, perioperative medicine, there's a lot of basics to that. You know, it's going back to the basics. And you're so very right. It's very translatable in some of these countries that may not have access to pulse ox, but they have access to other ways to improve surgical outcomes.
As you so rightly say, even in very, very high-performing centers, the absolute underpinning is doing the basic things really well and reliably. That's worldwide.
We'll definitely attach the paper in our show notes for the podcast, so that'll be great. We'll give that access to everyone.
Thank you.
Let's switch gears a little bit because Carol was talking about the international aspect. Take us into the U.S. and tell us a little bit about what you see happening, you know, in your neck of the woods and here in the U.S. on the perioperative medicine front. You know, a lot of people will say that we've been a bit behind the curve when it comes to other countries, but from your perspective, what do you see?
It's really interesting, and I think actually COVID has been transformational for our specialty within the U.S. As the chair of anesthesiology at Penn, I oversee 6 to 7 ICUs here. And what's been interesting is when these patients came in, nobody thought of anesthesia as the specialty that can make the most difference. But all of a sudden, at least at Penn, the pulmonary critical care folks and the anesthesia critical care folks said, we got this. I'd like to say maybe the anesthesia critical care were at the front, because we said not only are we going to intubate, figure this out, but we're going to figure out how to take care of them. And Carol, when you were in the UK, you did this, but in the US, it's not really quite as in-depth. And I think all of a sudden, I've had multiple interviews, as well as a lot of my intensivists have, being the ones, particularly because of our connections to places like China, Italy, the connections of the anesthesia intensivists throughout the world, to the point where lead articles in Wall Street Journal, New York Times, Washington Post, and I think it's given a new dimension to who anesthesiologists are. We're able to demonstrate to the public, to the lay press, and to the medical community our value in that perioperative period. Your own specialty of the nurse anesthetists at our place were amazing. Not only did they take care of the sickest patients, but they said, hey, we have such an understanding of pulmonary physiology that they took over in respiratory care within our ICUs. Wow. They did it willingly, and the patients got better. The mortality at places like HUP and other major medical centers was lower than what we saw in a lot of the rest of the world. So I'm excited about it right now. And it really was part of an international global network. I don't know if Carol feels that way, but people were just talking among the community. And I think now we have to leverage that idea that we get the perioperative period and that we can take care of pre, intra, and post in collaboration with our colleagues. We're part of teams.
I would totally agree. And I think that's a really important thing to highlight, Lee. We, through a network that we're part of called Global Health Data at Work, which is a group of hospitals sharing data, we were networked with Humanitas in Milan, with Maurizio Ciccone and his colleagues.
Of course.
And very early on, we had a discussion as a senior leadership group with the team at Humanitas, and we learned some things. For example, early masking of everybody that came into the hospital was one thing we did very, very early because of those networked connections. So I think we shouldn't let that slip. And this particular, the EBPOM group, for example, or the perioperative group internationally, could build on that. A number of very eminent centers here in the US and now have perioperative medicine fellowships. And I think so we're starting to see the framework of how to build on that. And I think I would agree with Lee that particularly anesthesia and intensive care have developed a much higher and very deservedly much higher profile after COVID. And I think we should build on that. In my organization, as you know, one of the things I've been interested in is telemedicine. And we already had a multidisciplinary group working with the geriatric team, the geriatric pharmacists. One of the things we've been thinking about in the past few weeks is how we use technology to break down social isolation of at-risk older patients who are confined at home. So we're starting to have very, very broad conversations based on the networks in the organization that we already have and we built. So I think the future, I would agree with Lee, coming out of this pandemic and this crisis, I think the future for perioperative medicine is very bright, and we should definitely take the opportunity and really build on that now.
Like Keck, we had to recruit a UK anaesthetist to really do a good job. Mike Scott, who is now with us, and he actually took over the tele-ICU. Yeah. And we have a remote hospital, Princeton. It's not that remote, but it's like 40, 50 miles. And he was able to set that up almost overnight and really be able to help their anesthesiologists and nurse anesthetists care for people remotely through our central unit. The other thing that really was exciting is that because of many of our connections in the perioperative world and perioperative medicine, the editors, I'll put a plug in for our journal, between Mike Scott, Cliff Coe from the American College of Surgeons, and myself, we started having conversations and got Frank Opelka. And if you look at the statements that came out from the American College of Surgeons about both the ramping down of surgery to create capacity and the ramping up, they were with the anesthesia community. Mm-hmm. We were together. That's unheard of in recent years that we did so well. So the idea of taking joint ownership of patients through the perioperative continuum, again, something that Carol's done for a long time, I've tried to do, Mike Scott has done, certainly throughout the world, that really is accelerated. And if you read the American College of Surgeons, and they have the 5 phases of surgery, and they have their red book, which is a lot about perioperative medicine, we are part of that team, and we're part of the Geriatric Surgery Quality Alliance. Is that, Carol, do you know the precise name? Because Stacy Diener is a member of that group.
I mean, there is the verification of the American College of Surgeons now.
That's the group.
Certification for geriatric surgery. So again, that's something that anesthesia, perioperative medicine has to be very central to, getting that certification to say you have expertise in delivering surgery for older patients.
Actually, in March, we released a report from the Global Council on Brain Health about perioperative brain health from AARP, and it was released in the middle of the pandemic, and I don't think it got the play. So hopefully with Carol's help and the Perioperative Brain Health Initiative, we will accelerate that, because, in fact, the social isolation is only making it worse. So Carol knows that. You've done some interesting work in that space.
Well, I think the whole impact of delirium, the concerns about delirium for older patients, number one, the social isolation when they're at home, but once they come into hospital, patients who are at risk of delirium, you add on that the social isolation within the hospital and PPE. You know, you have, we were just writing a paper and we talked about the perfect storm. So again, we have to be absolutely meticulous at ensuring patients get the best possible care, and we reduce as many factors as we can for at-risk patients in hospital and those undergoing surgery.
Yeah. Now, the last topic I wanted to discuss, well, a couple more. The first is the Brain Health Initiative that you guys have worked on, and the work, Carol, that you've done, you were just speaking about. Where do you see that going here in the U.S.? I know that it was getting some traction, and I would love, again, to be able to signpost people to more information about that. But tell us a little bit about your thoughts on that, Carol.
As we've just mentioned, I think with this pandemic, COVID, neurotropism is part of what the virus does. So delirium is essentially part of that. It's much more prominent in the discussions around it. And of course, you've also seen things on the media about patients who've been in ICU being, really suffering from delirium afterwards. So I think the whole topic is much higher in people's frame of minds. And I think as we go forward over the rest of the year, we should really build on that. My colleague, Justine Deco, who I've mentioned before, who's running our preoperative clinic at KET, we were asked to do a feature for Anesthesiology News to be released at the time of the ASA meeting, because it was very popular. It was a very popular topic at the last ASA meeting. So I think there's an awful lot of growing interest. Lee will know one of the things we've been working on within the Brain Health Initiative is to turn this into something very practical and accessible for busy practicing anesthesiologists. Because yes, we have the background of science, but if you're at the front line, what do I need to do tomorrow to make this better? So we've been working on that this year, and hopefully some guidance and things on that will come out later on this year. The AARP Global Health Council paper, also very practical help for patients and their families.
The Institute for Healthcare Improvement, the American Hospital Association, the American Geriatric Society, and Catholic Health put together the age-friendly health system. And that is, I think, as soon as we get past this immediate pandemic issues and get into a more chronic care state, older adults are the ones who are affected the most. We anticipate there will be a certain degree of PTSD when they have to come back to the hospital, a whole lot of issues around cognition. And one of Carol's colleagues just became head of IHI, as well as the Hartford Foundation, that's the other group, who really are aligned with us. So I think the opportunity to leverage this when sort of the standard quality improvement initiatives come back is going to take increased importance. And I don't know, Carol, if you think that IHI and your work with Kadar will make a...
Well, I mean, I think we're having ongoing conversations, but we would really like to work with that group, with the initiatives through the Brain Health Initiative. And I'm thinking, if you look at that initiative, they talk about the 4 M's are central to what they do. And the 4 M's are what matters to you as a patient, mobility, mentation, and medication. Now, again, if you think about what we do with enhanced recovery pathways, those things are very key. So there's a lot of overlap that we can really seek to develop and build on.
I wanted to talk about where you see perioperative medicine training and leadership going here.
I think by nature of what anesthesiologists, intensive care, well, people in perioperative arena, and I include surgeons, hospitalists in that, we're at very much a key part of the hospital, and we are involved with so many people around the organization. And so I think a leadership role in that area is very important. And I think things like the Institute of Medicine's quality dimensions, safe, effective, patient-centered, timely, efficient, and equitable care, those things need leadership. They need an understanding of improvement methodology. They need individuals to understand how they look for harm in the organization and how they work on projects to diminish that. So I think for our future perioperative medicine training and leaders, those are things that we should be looking at as well.
It's been interesting over the course of my tenure here at Penn, as I come to the end, because we're term limited, I'm watching my leaders take over as associate CMOs for critical care and perioperative directors. So the opportunity, having a piece everywhere, people are beginning to see it. And as we go more and more into value-based care, which has been a goal many of us have advocated, that becomes important. And what's interesting is at many medical centers, we're actually going to other disciplines, and in particular to management disciplines, and training anesthesiologists in formal management techniques, whether it be the Wharton School, Keck, Harvard, where Carol went for part of her training. So I'm watching that idea that it's not only the clinically technical skills, but not, I want to be a chairman and how do I become a financial director? But I think the more important thing is change management and implementation science. So I'll punt it back to Carol for her thoughts, because I think, when I met her, I said, this is a woman who understands, this is a person who understands those two particular fields.
What I didn't learn 10 years ago at Harvard and IHI, well, they teach it now, but less emphasis on change management. But as anybody out there who's tried to change things, you'll know it's not just about the tools and techniques, it's about the influencing skills and understanding how you make change happen from a psychological and a social perspective.
Yeah. In our closing, I would like to ask you just to tell us a little bit about what's happening with the International Board of Perioperative Medicine. I know both of you are co-vice presidents. Carol, do you want to start?
Well, I think we have an amazing group of individuals and leaders from around the world with actually a wide variety of skills. So I think we just need to accelerate our movement on that. And as we've said, we've got a good base to build on now. I think really we talked about creating a syllabus, so start to get that going and really build on it.
I think the key is not to say everything is the same, back to the implementation scientist in the room, but, in different parts of the world, what are the basic skill sets and some of those advanced traits so that everyone can learn how to do it at least at a minimum standard that we can elevate everyone. But for those places that are resource rich, they can even do more.
Yeah, I would agree.
Absolutely.
Basic skills and then building blocks on top of that.
Well, again, thank you all for joining us on Top Med Talk, and thank you for all the work that you're doing in the field of perioperative medicine, and not just in your own little microcosm, but for the entire world. I know both of you have impacted it greatly, so thank you very much for that.
Top Med Talk. Nick Majerison here. Thanks for downloading Top Med Talk. Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.